slime, whatever you want to call it. With our different procedures, we do different things. And it's not necessarily because we're overeating. It is about noontime and just about 12:30. And I was hungry. I took some of my supplements, especially the B vitamin. I have to eat when I eat those vitamins or take those vitamins because they upset my stomach. So I started to feel a little queasy. So I decided to make an egg, a half a piece of toast, and a little piece of tuna fish. And I'm stuck. Yes, I am. I guess I didn't chew it right or whatever. I do have a little bit of stricture. I think I do have a little bit of problem with gastrophoresis, self-diagnosis, but I think I do. I don't have a medical guru. I have no medical insurance, and I know the dangers of it. But I just wanted to document for my purposes. This has been going on for probably 6 months out of surgery. And it comes and goes. Here's the PB. I've thrown up twice. Chyme. Gastric juices, part of my ecosystem of my gut microbiome, cause inflammation. I have a video of a Mayo Clinic bypass or Lapband patient with vomiting strictures.
First thing we should mention is that what you need to do is ascertain what kind of bariatric operation they had. Sometimes the patient will come and say, I had bariatric surgery, or I had stomach stapling, and you may not know, are they truly talking about an old-fashioned vertical banding gastroplasty? Those are very uncommon now, or are they talking about gastric bypass? So first thing you want to do is ascertain from the patient, to the best of your ability, what operation they had. So if you are able to ascertain they had a gastric bypass, the next question you want to ask is, when was this operation? Was this operation last week? Was it last month? Was it last year? Because that's going to make a difference in how you treat this patient and how you figure out what's going on. So let's say that the patient comes in and for whatever reason they had their surgery last week and the surgeon wasn't available, so they call you. You certainly want to think about leak. Leaks are what kill patients in the first week.
So that's early on.
Often it's not clear as the patient comes in with some tachycardia and maybe a fever, and you're not sure, could this be a pulmonary embolism or could it be a problem within the abdomen? You can do one study, you can do a CT of the chest, abdomen, and pelvis with contrast and ask them to look for a PE and look for an abdominal process. And in one fell swoop, you can really rule out a lot of bad possibilities. So let's take a typical patient presentation. For whatever reason, the surgeon who did the operation disappears, and it's you who gets called to the operating room. Patient comes in, they're 4 days out from a laparoscopic gastric bypass. They come in with some abdominal pain, feeling unwell. It's a sweaty patient with, feeling.
Continue on with complications.
But it could be something else. It could be a pulmonary embolism. Maybe the patient is doing okay. They're just dehydrated because they haven't been eating or drinking after their surgery. And patients, they've gone from having a normal stomach to having a stomach the size of an egg. So they could be just eating and drinking very little.
Egg.
Maybe they have atelectasis and this is all a false alarm. Maybe it's pancreatitis. Or maybe this is just a normal postoperative course and they haven't been taking their pain medicine. You got to figure out what's going on.
Gas.
So, how do you manage them? Well, treat them like a trauma patient, get some good IV access. You can resuscitate them with some fluids, do your blood work, give them some antibiotics. It's probably not going to hurt. Get a Foley catheter in.
Uh-oh.
And again, think about confirming your diagnosis with imaging, but only if it's really going to change your management. So upper GI series, tempting, and if it shows a leak at the proximal anastomosis, that tells you what you need to do. But
okay, so you can review that when I link the card.
Drain and assume that any type of repair you do, whether you suture the hole closed or whether you put an omental patch on, assume that your repair is going to leak and treat as if it's going to leak. So put an omental patch, put some drains, so when your patch comes off, the drains will drain the extra fluid, and make sure that there's feeding access if you can get it.
More information, little nugget.
And the other is connected to the bypass stomach. So if that bypassed limb gets obstructed,
hernia,
you may not see dilated loops on a KUB.
It's a little bit technical, but you might understand it.
Doing pretty well, but they can tell you what the specific date when they first started having severe pain. The typical pain is epigastric. It radiates through to the back. Sometimes patients will tell you when they lean forward or get down on all fours, that relieves some of the pain because it opens up that internal hernia space. They'll tell you that they might have had this pain before because often with these internal hernias, the valve can get stuck in the hernia and then go out of the hernia and get reduced from the hernia and then go back in and then come back out.
Internal hernias, very dangerous.
Or slightly edematous bowel. Sometimes you'll even see the classic swirl sign where the mesentery is swirled in a spiral because it's herniated through an internal space. But more often than not, you're going to see a negative CT scan. So when that patient comes in with abdominal pain, have a high index of suspicion for an internal hernia. And if you're concerned about it, you can always go to the operating room to confirm your diagnosis. This is another patient I had actually about 10 years ago now. She had a duodenal switch at Mount Sinai, not a gastric bypass, but presented to an outside emergency room with severe abdominal pain. And they kept giving pain, injection of morphine after morphine after morphine, and she was still having terrible writhing pain. This was the KUB, and they thought it was a classic bowel obstruction. By the time we transferred her to Mount Sinai and took her to the operating room, this is what we found. And this is what you want to avoid. Luckily, this was from her biliopancreatic limb, and we were able to resect this, and she still had enough healthy bowel that she was able to survive this and do okay. But you don't want to let an internal hernia progress into this because...
Yowz.
Abdominal pain with gastric bypass intussusception as a cause for bowel obstruction with abdominal pain.
I'll link a card. Very informative, and you get a little nugget. All bariatric surgeries, you need to review this just in case. See you in the next video.